Good afternoon. This said good morning a few minutes ago. My name is Gretchen Wartman, and I'm Vice President for Policy and Program of the National Minority Quality Forum. Welcome to the Sickle Cell Health Policy Panel. Our speakers this session will address the health policy challenge from 3 different perspectives. Our first speaker will be Dr. Judith Baker. Dr. Baker is Policy Director for the 8-state Pacific Sickle Cell Regional Collaborative, which is funded by the Health Resources and Services Administration. Dr. Baker is Adjunct Assistant Professor in UCLA's Division of Pediatric Hematology and Oncology. Her expertise is in rare blood disorder healthcare delivery transformation, integrating policy, access to care, and clinical capacity building. Excuse me. Dr. Baker received her doctorate in public health from UCLA. Following Dr. Baker, we will hear from Mr. Randall Curtis. Mr. Curtis is President of the Board of Directors of the Hemophilia Council of California and co-chairman of the Hemophilia Utilization Group study. Mr. Curtis will describe for us the Hemophilia Utilization Group's methodology for measuring the burden of illness and hemophilia to support advocacy and education and the potential applicability to sickle cell disease policy advocacy. Mr. Curtis has a Bachelor of Science in Genetics from UC Davis and an MBA from California State University. Our final speaker will be Mr. Ryan Long, Vice President and Principal of BGR Government Affairs. Mr. Long plays a key role in BGR's healthcare practice, where he focuses primarily on life science and biotech issues. Mr. Long will share with us options for policy responses to the challenge of improving quality of care for Americans with sickle cell disease. Please hold your questions until all of our panelists have completed their presentations, and then they will respond to as many questions as the remaining time allows. Please welcome Dr. Baker.
Well, thank you, Gretchen, and thanks to everybody who's here. And I've got my timer, so we will make sure that we're on time. So I'm really pleased to be invited. We've done a great deal of work, although there's so much that lies ahead of us. And what I'm going to talk about is the importance of regional rare blood disorder synergies and looking at sickle cell disease as a rare blood disorder and how that impacts our ability to do policy and how to create healthcare delivery systems, build awareness, to really operationalize all of those essential public health strategies that are critical for improving population health. So a little bit about who we are. And when I think about policy, I think about it pretty broadly. I didn't know if you were going to anticipate talking about state legislation or federal legislation. That's a part of it, but that's not all of it. We look at policy as policy in everything that we do. So what we are here, my background is public health, and I've been working in the hemophilia space since 1990. And most of that was Diane Nugent, where we have regional system of care for hemophilia. And when we went after a HRSA, Sickle Cell Disease Treatment Demonstration Project grant in 2014, we wanted to really disseminate the best practices and the successes of the hemophilia model, tailoring it, of course, to sickle cell disease, but really moving the needle, using that regional approach that's really cross-sector collaboration. That's, I shouldn't say a purpose there, but really operationalizing cross-sector partnerships. And on the pink side of the slide, those are the 5 areas where we build sickle cell synergies that I'll walk you through. In awareness, clinical services, health workforce development, insurance coverage, and CBO capacity. Policy is in all of that. It's not just my idea. There's a wonderful, brief, new article published last year in Preventing Chronic Disease called Public Health and Rare Diseases, an Oxymoron No More. So we've heard throughout the session about geography. I call it regions. That's what we're really talking about, is contiguous spaces, so that you're not just developing a center of excellence, and that center of excellence doing phenomenal work for its patients in its own institution, but the obligation to build capacity outside of your institutional walls throughout your city, throughout the rural areas, throughout your state, throughout your neighboring states, throughout the country. And in no less than 4 or 5 places within this network, the concept of regionalization was mentioned for surveillance, provider network development, databases, and clinical centers of excellence. So take a peek at this article. I was thinking about sickle cell and hemophilia and the commonalities and the differences, and this is just my take, my opinion, at different levels of public health. And at the patient level, there are so many similarities. Pain, both chronic and acute, lifelong, creating illness burden, economic burden, utilization burden, resulting in the emergency rooms, hospitalizations, work and loss of school days. At the patient level also, there's home treatment. Hydroxyurea is something you do at home, right? Same thing with hemophilia, with injecting your factor concentrate. The isolation, the stigma, the caregiver stresses, disparities. Yes, of course, more racial and ethnic disparities in sickle cell disease. But hemophilia is an equal opportunity disease, and we mirror the population of the US. So these are all similarities in the patient groups. Some of the differences, though, I've found arise in the level of the healthcare delivery system, insurance and advocacy, and the resource area. And where we see there is, in hemophilia, we're very fortunate. We have regional and local centers of excellence, surveillance that's national. And sickle cell, not so. Some, but not quite yet. There's similarities, though, in the shortages of knowledgeable providers and the adolescent transition to adult care. Many gaps, similarities there. And also, I should note that most of the hematologists who take care of sickle cell and hemophilia, they take care of both populations. It's only what I have seen is in the largest of the cities where there is a separation, where there's enough patients to hire physicians who really have a yen for one or the other. But the docs cross-cover, the nurses cross-cover, the training is similar. And then in insurance and advocacy, there's gaps that hemophilia and sickle cell share in reimbursement and access to specialty teams. CBO capacity building, there's a lot of it in hemophilia, very intentional over the years. And there's some in sickle cell. And then the level of resources, more in hemophilia, less so in sickle cell disease. But it's growing in sickle cell with our new pharma partners, particularly. Just a quick, this is where the hemophilia treatment centers are. There's about 140 centers throughout the United States, and those are the hemophilia regions that were devised, updated in 2014, but we've been regionalized since 1990. And don't let the big white spaces on the left side fool you. For example, in Nevada, which is part of our hemophilia region, we have 6 ongoing outreach centers, including on Indian reservations. And in Hawaii, we have outreach clinics in neighboring islands. Also in Montana and Montana and Wyoming, they are cared for by the Denver group. Hemophilia, the pain, internal bleeding, also soft tissues as well as joints and muscles. That's something that we can prevent and reduce, not totally eliminate. But with good access to care, resolution without some of the terrible crippling that we'd seen in previous years. And we've had national database, and that's just one slide from 20 years of one of our national databases showing the increases in the numbers of patients by diagnosis. Let's move on to sickle cell. Something wonderful happened, and I'm not sure what. Donnell knows. Something happened in 2013, 2014, such that HRSA decided to regionalize their sickle cell treatment demonstration project grants. And Dr. Diane Nugent and I and Children's Hospital Oakland, Elliot Wyszynski, Marcia Treadwell, Mary Brown, we went after one of those grants and we got it. And I think one of the reasons that we got it is we have such a combined synergies in regionalization and sickle cell specific clinical diagnosis and treatment. And that's our Western states for the treatment demonstration project. And let me go back quickly. But how do you create a region from nothing on the sickle cell side? Well, one of the key things that we did was we convene annually, where all of our state leads come and they tell us about their strengths, their weaknesses, their challenges. And that's where we learned for the first time about the immigrant population in Seattle, Tacoma. And then Idaho said, we have them too. And that led us to work on some of the language diversity for our resources. And this is our structure. We have a variety of departments, and policy and partnerships really circle all of it and have an impact on all of it. One of the policy things that I instituted was a government partners work group. It's not enough just that we get to know each other better within our region of the clinical specialists, but I reached out. These are all of the regional HHS offices, the HHS regions, and they have offices of maternal and child health, CMS's Center for Medicare and Medicaid. I reached out to those partners and said, will you partner with us? And they said yes. And so we've been having annual meetings in the San Francisco Region 9 offices annually, and we teleconference in our partners from Region 10, and we have the directors of all of those organizations that you see bullet pointed. We brought CMS to the table, and they have been instrumental in giving us, we've raised their awareness about sickle cell disease. They raise our awareness about emerging policy issues that we can provide public input on. They help us troubleshooting some of the problems that we've had with accessing the Medicaid databases that you've heard talked about. And they've given us strategic linkages. Some in particular that we'll mention is, for example, the Hispanic population. I said, give me the one name of the best mover and shaker that you know in the Hispanic health workforce development. And they did. And we developed a great partnership with that group, which you'll hear about momentarily. I would love to replicate, disseminate this throughout all the TDP regions. And of course, another synergy is that we've now, with these partners, we're using them appropriately when there are emerging crises in hemophilia, benefiting both hemophilia and sickle cell. And this is just some of the pictures from our recent government partners work group. So the language literacy. When we heard about the French language needs of some of the African immigrants, we said, well, when we're creating our new hydroxyurea brochures, we're going to create them in English and Spanish and French. And we did, and these are available online. And I approached Mary Houlihan at the CDC to kindly consider translating some of their wonderful CDC fact sheets into French, and they did it in time for us to present that to the African Immigrant and Refugee Conference that we were invited to for the Northwest region, as well as the national conference. So CDC moved, and we're so thrilled. This is another area of operationalizing policy, making our CBO, Mary Brown, and her staff absolutely invaluable at the table, designing and staffing that new MLK adult sickle cell clinic. And those are some of the areas of the clinic, as well as in red, the peer navigator, the community health worker, the sickle cell nurse educator. That's from Mary's staff. And the data management funding from CIBD, from Diane Nugent's shop, from our HRSA grant. Workforce develop is another way to operationalize policy. So the National Association of Hispanic Nurses is that key mover and shaker group, and we've been working with the LA, Los Angeles chapter, the Orange County chapter, the Arizona chapter, and even at the national level, we've been invited to present on our work. And they adopted sickle cell disease as one of their priority areas in their ACA minority outreach enrollment grants. So we have lieutenants on the ground that we would never have imagined taking the message of sickle cell, working in conjunction with our CBO, the Sickle Cell Disease Foundation of California, to create Spanish and English materials. So they're out in the field educating. They've adopted this. We're also implementing Project ECHO, which you've already heard about. So that's the current. The next generation is that we've reached out to Charles Audru University, where the Hispanic Association Mover and Shaker, she's on the board of trustees. And so we've created a new alliance where we're going to develop a blood disorders curriculum for the next generation of docs, nurses, public health, the PAs, to create their excitement, because the Charles Audru University is a historically black college and university, minority serving, so that's to grab those young minds. And then in the planning phases are with the FQHCs, the primary care associations, et cetera, because we know a lot of people with sickle cell disease are seen in those community clinics. Why Hispanic nurses? Well, this is from this wonderful report that Mary Houlihan, Susan Paulokonis, and Faith Rader put together that we've used many times to document the need. This is moving data to action. Insurance policy, we've been, instead of me typically writing policy input letters to the state agencies just about hemophilia. We combined sickle cell and hemophilia in a single letter. Strength is in numbers. For example, recently, adult immunization coverage. We didn't talk about only hemophilia, we talked about sickle cell as well. So these are some of the other areas where we've been synergizing hemophilia and sickle cell because the issues are the same, needs for better policy. So in wrapping up, the context that I would encourage us is rare disorders. That you need a spoken hub model, you need outreach clinics, you need regional oversight of these centers of excellence to identify where, if there's no center of excellence in the state, for example, in Nevada had no center of excellence, and we helped them develop a sickle cell pediatric comprehensive center as well. Policy is really in everything that we do. It's critical to have your CBOs at the table right from the beginning, not as an afterthought. Cross-center partnerships are absolutely essential in moving sickle cell policy forward for awareness, clinical care, workforce development, and stable resources are critically needed. So that's where we're reaching out to our industry partners, new and old. And we talked about sickle cell disease in our work at our recent hemophilia regional conference, kind of coming out of the closet, so to speak. And we invited Mary Brown there, so she was getting acquainted with some of the the hemophilia CBOs and finding synergies there. So it was well received. And we are really thrilled that this work, I really believe this was going to get us out of our silos. We were thrilled to be invited to CDC to talk about it recently in January by Craig Hooper, the head of the Division of Blood Disorders. There's a lot of great public health evidence-based work about partnerships and what works. This is a bibliography for those of you who might be interested. And I want to thank you very much for your time.
Okay. I am a 63-year-old severe hemophiliac, which in my community makes me like Methuselah. I've been building hemophilia and bleeding disorders databases since 1984. It's kind of a weird hobby, but it's my hobby. But I've also worked for 25 years for George Cunningham doing newborn screening in California. And I participated in the RUSH and the FRESH, and now with the new Pacific Sickle Cell Regional Coordination Project. So there's been a lot of comparisons lately in the literature of hemophilia with cystic fibrosis and with sickle cell disease and cystic fibrosis. But I think that hemophilia and sickle cell disease have a lot more in common than we do with cystic fibrosis. Once again, and Judith has just finished doing a very good job of showing how that matches up better. And what I'm here to do today is to show you the tools that we use in hemophilia and bring that to the sickle cell population so that we can choose those parts of it that work well for sickle cell and build a sickle cell tool and just use what works for you. All right, what's going on here? This one? That one? That one? Oh, I hate this. Okay. So the hemophilia utilization group study, that doesn't really roll off the tongue very well, but it makes a nice acronym. So it was designed initially in the late 80s, early 90s to protect the treatment center system that we had in place in hemophilia. And it has grown to become one of the largest independent cost of care and burden of illness projects in the United States. And the whole idea behind it was to publish kind of like a baseline of what kind of care we had at the time. And so it was defensible against, let's just say, errant legislation or other funding cuts or even At that time, we were very concerned about the impact of managed care and how that would cause great problems for those of us with hemophilia. And so I'm the patient on the steering committee. So the model is to have this research team that's multidisciplinary. So we have a doc, a nurse, social worker, and data coordinator. And also to utilize the research team at the University of Southern California in their School of Pharmacy. They have a department of pharmacoeconomics within the School of Pharmacy. And that provides us with that slave labor grad student component that you need to get these research projects done. It also gives us we were able to tap into all of these different specialists in quality of life and burden of illness language to help us cost out the different variables that we put in our papers. We're using a similar model now with, I don't know if Mark Skinner came to join us yet, but we're using a similar tool in 17 other countries and teaching some of these developing countries how to collect this same quality of life data from the patient organizations and how to build slide decks to present to the ministers of health to improve care in those 17 countries. And we're going to add 5 more countries next year, including, and we're going to try and go after China and an Arabic-speaking country as well. So it's a model that's been used successfully in a lot of different things. The other thing we do is we try and do multiple funding from different sponsors, so that it doesn't seem like it's being focused on one particular product or another, and that's been useful too. Okay. So the next two slides are just a subset of one of the studies we did on young folks with young adults with hemophilia, because we were noticing that they were showing more burden of illness. At least a third of them were showing more burden of illness than they should have been, because these are guys that had been on prophylactic hemophilia care, had perfect joints, and by the time they were transitioned out at 18, they shouldn't have any problems at all. But here we have them. This is an example of one of the things we do with this patient-reported outcomes is, these guys are reporting that they are only working part-time just because of the hemophilia. And obviously, as you get older, you get more morbidity and more health problems. But once again, we're seeing, like these guys 25 to 34 with, arthritis, like, 44% of them are reporting arthritis. And part of that is that 18-year-old invincibility problem, right? And particularly if you've been on a treatment protocol that's worked for you for 18 years, you all of a sudden decide, I've actually had these morons tell me. It's like, well, I don't really have hemophilia. It's like, come on. So part of the problem is that my colleagues in the treatment centers are kind of a threefold brochure kind of group, and these guys are talking on Snapchat and Instagram, and there's no information going there. So that speaks once again to the community health workers getting out there pounding on the doors and beating some sense into these guys. Okay, so. In hemophilia we bleed. In sickle cell disease, there's crises. We have arthropathy. You have avascular necrosis. So there are different. The tools have to be changed, but the same methodology works well. What we do is we use a non-specific quality of life tool, the EQ5D, and that way I can, when I'm presenting to, whether it's a healthcare conference or a legislator or something like that, I can show the difference between hemophilia and cystic fibrosis and chronic pulmonary disease, and I can just do a bunch of comparisons across, and the normal population. And I can actually even show you that the quality of life, at least on the mental quality of life in the kids, is actually above normal. Because we've been giving them all this factor and telling them how wonderful they are. It's like that, you get a ribbon just for showing up. They think that, they think life's great. So they actually have a higher than, I call it my happy hemo slide. So let's blow in this here. So once again, the USC determines the costs from the literature. Reimbursement teams go out in whether that's your social worker or the specialty pharmacy or in my case our advocacy council, and we go and do in-service at insurance companies, and you have to do these every year because the insurance company people turn around. I think to have these tools in your hand, because I believe that sickle cell disease is going to change, and to have a baseline showing what the burden of illness was in 2018 is going to be a key, so that you can measure that bump with these new drugs and new therapies that are coming along, and to be able to use that and put that in front of people and say, yes, it does cost more money, but here's the benefit to that. Here are the less days from work or school that are being missed. And the other thing we want to collect, I think that is not being collected, at least from what I've seen so far, is that where there's a lot of data on hospital admissions and ER visits, there's a lot of time that's lost on either side of that when people are avoiding going to the ER. And that is days lost from work or school or activities of daily living or whatever. And I want to capture that because that's part of that true burden of illness. That impacts the patient and it impacts their family. Now, I'm going to blame this slide on Jude because she always uses too many words and too many bullets and squeezes too much stuff onto a slide. But I think the main thing is we need to be able to show that it saves, we need to be able to show the payers that it saves money in the long term. And that the patients, particularly with chronic illnesses, do not change insurance companies every 2 years. And if you don't take care of them now, you are going to inherit those costs on the backside. And I got to tell you that we wish in hemophilia that we had had a baseline before we started because that would be very helpful to us now. So our goal is to set up this study. We're talking about an N of maybe like 100 patients with 4 major treatment centers in sickle cell and do this. And it's not a longitudinal study. It's not a surveillance study. It's a one-shot cost of care, burden of illness study. And then I want to share that knowledge with the sickle cell community and have people from the sickle cell community take it over, and I can go back to bleeding and doing what I do. So that's it. I don't know if I fit within my 10 minutes.
Well, that's a tough act to follow, but I'll try. So I want to talk about the policy landscape for incorporating new therapies into the Medicare and Medicaid programs. For the last couple of decades, the standard of care if someone has a crisis and has to go in the hospital has basically remained unchanged, and people are usually admitted for 7 to 10 days. They're often given opioids to manage pain, but we've really done nothing to reduce the amount of time necessary to have a crisis sort of run its course, reduce the number of days that people are in a hospital, reduce the amount of pain associated with a crisis. Luckily, a few different companies are doing a lot of research and development in this area, and we're hopeful that within the coming years there will be new therapies approved to treat a sickle cell crisis. So, all right, you're going to have to teach me how I did that. So if a new therapy is approved on the outpatient side in Medicare, if it's physician administered, it's going to be paid for under what's known as the average sales price, basically automatically covered. If it's an outpatient drug that is not physician administered, it'd be covered under Part D, and people would be able to find a plan that would have that therapy. And in Medicaid, as long as the manufacturer has a Medicaid rebate agreement, the therapy has to be covered. What we see, though, is in the inpatient side, because of the unique nature of the way the Medicare inpatient payment system is set up, there's actually a disincentive for facilities and hospitals to introduce new technologies, regardless of how efficacious they are for patients. So, just in explaining it real quick, a hospital's paid a set amount for an individual based off of their diagnosis. So there are 2 sickle cell diagnoses, or DRGs, diagnosis-related group. That amount, it may fluctuate based off of the wage cost for a hospital, but the base amount does not change whether the person's in the hospital for 3 days, 7 days, or 14 days, or the intensity of services the hospital has to provide to that patient. The other thing is how you get to that payment DRG is based off of the historical average cost of caring for that patient. And that seems to work in most circumstances, and it's designed to ensure that hospitals provide care efficiently. The problem comes when there are new therapies that are approved by FDA and introduced into the system. There's actually a disincentive in the inpatient system for hospitals to use those new treatments because they're not going to get reimbursed for them. So you can see when HHS is setting the 2018 payment rate, they're going to use cost data in 2016 because they're setting that payment rate in 2017. The effect of that is if you have a new therapy that's introduced, let's say on January 1, 2017, it's actually going to take a full 2 years until the DRG payment reflects the cost of that new therapy. If it were, let's say, September of 2016, it would take actually 3 years for that new therapy to be rolled into and reflected into the reimbursement rate. So if you're a hospital and you have a new therapy that's introduced, you have the situation that you could not be reimbursed for that new product and therefore potentially not provide it to every patient that may need it. So in 2000, Congress recognized this and they created what was known as the New Technology Add-on Payment. And an NTAP designation is given to a new therapy, whether it's a drug or device, if it meets 3 criteria. It's the product new, would the DRG reimbursement not adequately reimburse for the product, and is the product for an unmet medical need, or is it clinically superior to the existing treatments? So if you get an NTAP designation, the hospital is reimbursed the lesser of either the cost of the product or the cost of treating that patient in that DRG when using the new product. Presumably, let's take sickle cell as the example. Currently, it's a 7 to 10 day hospital stay. I think with some of these treatments, we're hopeful that would be cut in half. So the cost of treating the patient under the DRG would be less because their hospital days would be less. But when you add on the cost of the new therapy, it would exceed what their DRG payment would be. So they would get either, again, 50% of the cost of the product or 50% of the amount that using the product exceeds the DRG. And like I said, that DRG payment will last typically 2 years, potentially 3 years. But once that new therapy is rolled into the actual cost of treating patients, the add-on payment goes away. There have been criticisms of the NTAP program. and two main ones. One is that CMS has been too conservative in granting NTAP designations, particularly for drugs. There have been, I believe, up until last year, 4 designations for NTAP since the program was created in 2000. Since the fact that they have been a little bit conservative, that means that access is put in jeopardy for those people that would rely on these new payments. The other criticism has been that 50% reimbursement rate is too low and does not fully address the disincentives facilities may have in using these new products. There's been academic literature to say a more appropriate amount would be something akin to 80%. Additionally, there is no analogous NTAP add-on payment in the Medicaid program. So for sickle cell, I think the patient mix is about 25% Medicare. It's about 50 to 60% Medicaid. There are some that have private commercial insurance. So the lack of a Medicaid add-on program for new technologies will particularly hit sickle cell patients the hardest and jeopardize their access to these new treatments. So in discussing with various academics, stakeholders, advocacy groups on what we could do to take away the disincentives related to new therapies. We wanted to enhance the NTAP program while still addressing particular concerns that members have related to the cost of new policies and incentives that may be created on the other side. So what we said, we've been working on a proposal that hopefully will get introduced in Congress soon. But it would say if a product has been designated by the FDA as fast track, it would automatically receive an NTAP designation, a drug. And fast track is defined as drugs that treat serious conditions and fill an unmet medical need. An unmet medical need is defined as providing a therapy where either none exists or that therapy is going to be clinically superior to existing therapies. We think that this has two benefits. One, it takes away some of the arbitrary nature of CMS's decisions related to NTAP, but it also takes away the need to have a duplicitous review by 2 agencies within the same department. If FDA has said this treats an unmet clinical need, treats a serious and life-threatening condition, that's really their area of expertise, and you don't really need CMS coming back and doing another review and potentially counter their FDA's decision on that subject. The other thing the proposal would do would be, again, instead of that 50% reimbursement where there still is a large disincentive, or at least not the proper incentive for hospitals to use these new therapies, it would say the hospital would be reimbursed at 80% of the cost of the product or 80% of the amount that the use of the product exceeds the DRG. Some people would have said, well, why don't you do 100? And I think a lot of us would have liked that, but in talking with some of the members and potential sponsors of the bill, there was concern that if you set 100%, that there wouldn't be any cost pressure related to the pricing of the drug. So 80%, I think we think strikes that balance between having some of that downward pressure, but also ensuring that hospitals and facilities are adequately reimbursed for these products. And then the third thing that it would do, it would create an analogous reimbursement, NTAP reimbursement system under Medicaid. It would basically say if a patient would have gotten a NTAP add-on payment in the Medicare program, they will get that payment in the Medicaid program, and that states would receive a 90% Medicaid match from the federal government for these payments. And that 90% match was designed to ensure that there wasn't a disincentive from states to actually cover these products when they're looking at their budgets and their Medicaid programs. So, like I said, we have been having discussions with members on the bill. I would expect that once we get it introduced, there will be probably 7, 8, 12 different ideas on how to change it. So we're certainly open to suggestions on how to do that. I think at the end of the day, what we want to achieve is the ultimate goal is making sure when new products are approved for this population that they actually get to the patients that need them. So, thank you.
Thank you. We do have time for a few questions, but I do want to make a comment based upon, excuse me, the presentations I heard this morning and today, and thinking back to the theme of this conference, which is building sustainable communities, creating data-powered alliances. And regardless whether we're regionalizing geographically contiguous interests, healthcare interests, or documenting and reporting on the burden of illness, or developing policy responses, we have to have data that we translate into evidence that resonates with those who have the political and economic will to bring about change. And at this stage of my life, I no longer believe in magic or good luck. I recognize that things occur because they ripened, because people have been working behind the scenes to make it happen. And in order to bring about change for a patient cohort, like adults with sickle cell disease, we have to find a way to take a population, a racial and ethnic population, with a disease that is defined as a rare disease, and empower it to get the attention of people either on the Hill in a state or the Hill in Washington, D.C., who create the policy environment that enables the positive change to occur. So I'm asking our panelists to speak to it through that lens, because it also occurs to me that policy interests are not geographically contiguous, but they are issue contiguous. And how do we communicate around this country in a way that we enable people to understand that they have a common interest and bring that will together to bring about change? So I don't know if some of my panelists want to speak to what may be a first question, or if we should open it to the audience. Is there a question? Hi.
I can speak louder.
Okay.
Natasha Lee from the American Society of Hematology. So I know that it was not brought up during this talk, but since we have so many sickle cell disease advocates in the room, I want to kind of ask a question that has been floating around ASH in terms of inquiries from our providers around red cell transfusion and denials, especially Medicare denials. Has anyone been experiencing this? The situation that we've been made aware of has to do with the very old NCD for red cell transfusion and sickle cell disease, which does not explicitly state sickle cell disease, but also says that this is not an exhaustive list, whereby insurers have been using this as a denial.
So your question is whether people are aware of these denials?
Yes.
I don't know. Judith?
Well, that particular denial, no. But I think that doesn't mean it's not happening. I think it's because there's a lack, at least on the sickle cell world, of a system in place whereby the centers of excellence, the sickle cell centers, and the CBOs have a regional point of contact to inform and to determine if it's just an issue happening in one state, one county, one locale, one insurance program, or if it's something statewide or nationwide, because that is exactly what we do have in hemophilia. And I am that point person for hemophilia for our region. And I have to remind my centers, because there's always new people, and I say, if you're having a problem, if insurance is delaying, denying, or modifying your treatment plan, or a patient organization, a CBO, hears about something, let me know. I don't want any PHI, I just want a brief paragraph. And what do? Is I find out I immediately engage my entire network and I say, is this happening? Is this happening in one place? Is it happening elsewhere? So I identify if it's an exception or a trend, and I immediately link to the Hemophilia Council of California because they have a paid lobbyist, and I say, this is happening. So Randy's group engages his lobbyist to go to, I alert Medicaid, but I alert my CBO partner because they have access directly to the state health department directors. So this is what we have in hemophilia that I'd love to see happening in sickle cell as well. Randy?
And to that same point, last night when I was having dinner with Mary Brown, we were talking about a program that we've been doing in California for 20 years or so, which is our Future Leaders program, where we take young people between the ages of 16 and 22, and we spend a day with them, teaching them how to talk and present the same kind of data that I collect, and how to tell their stories to a legislator who has a short attention span and needs to see bullet points of key things and to get their story across. And then the next day, so this happens on May 9th this year, and then on the next day, on May 10th, then we take them to the Hill, and we have meetings with each of the members of the Assembly and the State Senate, and we have people from their district go to them, and we have an audience with them, and the kids tell their story, and then we come in with a very short playlist of, we want you to support this and not support that. And they appreciate us. They like the kids, and then they also like to, to get the ask has to be short. And because I was sitting there telling Mary about it, she says, well, we should have the sickle cell people doing that too. I said, well, do you have any that could come up on May 9th? She says, yes, I have 2 right now. And so as of last night, we've invited Mary's 2 folks from Southern California to join us this year on the Hill in Sacramento to show them how it's done. And I now have 3 members of my board of directors who were raised through that program, and they are the future leaders, and it's actually working.
Yeah, I wanted to address the point that you raised in terms of marrying, the policy. And I think it does get to how you structure the system of care. I think that really helps a lot, both on the federal level and the state level. We mentioned Medicare, and DRGs were mentioned. And one of the things that hemophilia has is a pass-through payment for clotting factor. And that came out of a marriage between the community and the providers being able to advocate. And I think what the regional system does is brings folks together with the common purpose that you mentioned, the common issues that can then be brought to the federal level. And sometimes when there's not success on the federal level, there's success on the state level. And so, the reimbursement piece is going to be key as we get new drugs coming in. And one of the things that the regional system helps with is reimbursement. So again, in Medicare, one of the things that I do outside of sickle cell is reimbursement for clotting factor. There was an issue with outpatient reimbursement for clotting factor. It has to be billed in a very unique way, and it actually varies by fiscal intermediary. But when that issue starts to surface, I'll get a call, and then I can make sure that the calls get to every single center that deals with one of the fiscal intermediaries in the country. And that comes directly out of the regional concept, because they know this person has some expertise in this area. Let's get him and let's spread the word. And I think if sickle cell models that, that's how we're going to be able to fight the battle both on the state level when we talk about reimbursement and on the federal level as well. But I do agree that we do have common issues that do go across any geographic, burdens that are there. But I think having that unique, and I think we have the skeletons in place and we need to fill it out. And so you have SCDA that has to play an instrumental role in making sure all of the CBOs are there. What I would love to see is a regional collaborative of providers. And we have some providers here that can do that on the provider level to go along with the patient level. Because I think at the provider level, that regional network is going to be important.
Right. I'm going to agree with that. I think what I latched onto was your statement that when the issue surfaces, then I take action. One of the things I believe we have to do is make sure they surface. And I'm going to go back to refer back to a statement that Dr. Puckrin made this morning, which is that health status disparities, poor health care outcomes are unfortunately often intentional because the failure to make a decision to assure that resources are available to support the health of particular populations is a decision that has consequences. And as we communicate with policymakers or influencers, regardless of where they are, we have to communicate to them that their failure to make the decision that supports the health of those children or the health of citizens in a particular region of this country redounds negatively to those populations in measurable health status disparities, increased costs to the system, which they all claim they want to avoid, but they are not necessarily making the decisions that would help us avoid those additional hospitalizations or additional doctor's office visits, or the poor outcomes that result from the inability of the patient to subsidize the system's failure to provide the care in which they have already invested to a significant degree. So I think, yes, reimbursement and building the systems is an important part of it, but also getting the engagement of the communities so that they understand how to influence health care structuring the same way they understand they need to influence the educational system or other kinds of consumer issues is equally important. And reporting information in a way that it cannot be ignored is important. And I'm going to once again say the National Minority Quality Forum has had some success in doing that because we do collect and analyze the data, and we will share it in a way that legislators and others makes them understand how their constituents are affected by their lack of engagement. Let me put it that way. Are there any other questions?
I'm just curious, Mr. Long, about
Can you, I can't hear you, I'm sorry.
Sorry, I'm just curious about the program that you mentioned, Mr. Long, and whether or not that's time limited, and whether or not drugs coming behind the initial drug will have the same opportunity to get the kind of classification for discounted.
So it is time limited. If you go back to the slide, the NTAP program is designed to be for 2 or 3 years, and that 2 or 3 year period allows for the cost of the drug to get incorporated into the reimbursement system. So you don't need it to be permanent. Presumably, the whole DRG for the 2 sickle cell DRGs will go up over time. You just want to make sure that there's enough of a incentive to use the products while the DRG payment is catching up to the introduction of the new technology. As it relates to future products, if the product is clinically superior, then yes, it could get that designation. If it's not, then it wouldn't get that designation. It wouldn't get the added reimbursement. That being said, for future products, once the DRG catches up to the introduction of that first product, the subsequent products are going to get the benefit of the fact that the overall reimbursement rate is higher for treating a sickle cell patient. So they may not get an add-on payment, but they will benefit from the fact that the first product was introduced and the cost of that product has been incorporated into the reimbursement system.
Thank you. We're 4 minutes from close. I'm not sure we have time for another question or answer unless there's a very short question and an even shorter answer. Well, then I thank you.
Okay, wait, I got one more story.
A little bit?
Talk
Okay.
Real quick.
2 minutes.
2 minutes, I can do this. So my colleagues in Poland were having trouble getting clotting factor to the patients. The patient organization took pictures, really ugly pictures of kids having really bad bleeds, with big elbows, big knees, all the rest of the stuff, and pasted those all over the billboards right before the election, saying, "This is what your legislators are doing to your children." They were all thrown out. And all the new ones that came in wanted to talk to the hemophilia population to find out what they could do to help.
Thank you. Thank you.